Hello, I'm Marcus, Europe Policy Lead at Privitar. This is a recording from our joint event with One HealthTech London, which took place on the 30th of September. We discussed some of the challenges around using health data, along with data on the protected characteristics, such as ethnicity, to understand health outcomes and inform decision-making. COVID-19 shows just how important it is that we get this right. We've all seen emerging evidence that Black and Asian men, for example, are disproportionately affected by the virus. We'll hear from three expert panelists who I'll introduce in turn. First, Sonia Patel. As Chief Information Officer at Nhsx, Sonia leads the tech and data vision for the NHS. She is passionate about delivering digital healthcare, but also about promoting diversity and inclusion. Her remarks will focus on the imperative to collect good quality data in the first place, to help us understand the difference that demographics can make to health outcomes. Second, we'll hear from Cerys Wynne-Davies, a partner at the law firm Pinsent Masons. Cerys specializes in intellectual property, data, and AI. She advises global pharma and biotech companies on issues like privacy and data-driven research. Cerys will take us through some of the legal and regulatory requirements that we have to be mindful of when sharing and using data on health and demographics. Finally, Noah Dagan joins us from the Khaled Research Institute in Tel Aviv. Noah is head of AI and data-driven medicine, and as a data scientist, she specializes in machine learning for personalized healthcare. Noah will explain some of the challenges in actually using data on protected characteristics, like ethnicity, to build models. Our three speakers will look at the three different stages of the data lifecycle. First, Sonia on collecting data and making sure that it's good quality in the first place. Cerys on the legal and regulatory requirements for using it responsibly. And Noah on some of the practical considerations for using data like data on ethnicity in machine learning projects. Sonia starts by sharing her thoughts on the need to factor in ethnic diversity into our understanding of delivering care at a macro, meso, and micro level. At a macro level, recognizing different demographic characteristics is important as we drive healthcare innovation. I'm afraid we had some technical glitches on the evening, which means that the recording didn't quite capture Sonia's first point. However, we'll join her as she discusses the meso level, where demographic data highlights diversity within communities. I'll hand over to Sonia.
So just reflecting, that's the macro level. On the meso level, it is so incredibly important. If I think about general populations, we're looking at, particularly in the NHS, at a kind of system arrangement, which is really about how we join up care between health and social care. So it really delivers person-centered care, which is our ranges in populations of about 1.5 to about 2.2 million citizens. It's so incredibly important that our populations from the north to the south look very, very different. So we need to be making sure that actually we're cognizant in actually delivering of services, that at the heart of actually starting to care for an individual, that we are collecting the right level of demographic data or protected characteristics data all the way through the output and outcome of their care too. And it shows that we're not only diverse as a population, but diversity exists within different sort of systems of geography too. On a micro level, it's so incredibly important that we ensure that we collect the right ethnicity data to ensure that we are delivering the right care to an individual. And therefore, what we don't want to do is inadvertently affect parts of the population by not ensuring that we are collecting their right demographic data, and that goes as far as sort of ethnicity, kind of cultural background data. But it also means that in terms of the support and care that they receive, that it's rightly targeted to support them. So this is a really interesting space, and I think one which actually COVID shone a light, but there's so much we can learn from in COVID, in terms of making sure that in our design of data capturing systems, that we are inclusive in understanding the population we serve and ensuring we're collecting the right demographic data at the point of care. And it's so important. And I cast my mind back about probably 10 years ago when it was a kind of mandated requirement that all our citizens' data set ensured that we collected up to 95% of ethnicity data in the data that we shared back. And so it's not new. So we are aware that we've needed to collect this data for some time, but over time it seems to have got lost. And actually it's reinforced in the heat of a pandemic that we recognise that certain parts of the population, and that all stems back to, whilst I think it's, and I'm not the scientist, but definitely I think it's about 98% of our DNA, the 2% variant that we have is the 2% which actually, as we've seen, disproportionately affected a particular part of our population, both on gender and on ethnicity too. And why it's also important, it's not just about the sort of treatment of medicine or those that are disproportionately affected by a disease or a condition. It's also to make sure that the interventions are appropriately supported. So we're doing quite a lot of work within Nhsx to make sure, whilst we're empowering citizens, we're also empowering communities. And we are seeing some very interesting kind of feedback. So a skin graft of a black person with cancer is very different from a skin graft of a person that is white of nature. And for that reason itself, it's not only important that we collect the demographic data, it's to ensure that we are actually providing the best sort of resources and advice and guidance to those that are delivering care at the grassroots. And so where do we go next with this? So putting particular emphasis across the NHS in its entirety to make sure that ethnicity data is consistently captured within all our citizen data sets. Now that was a mandate that came out from Simon Stevens to say data is our starting point to make sure that actually as a kind of full life cycle data, it is informing the right decisions around care, research, treatment, and medicine. So there's incredible efforts that are going in at the moment to make sure that all our citizen-facing data sets absolutely capture the right level of sensitivity in terms of the ethnicity data. Now, it will take time, because that's not just about making sure we've got the capture systems, it's making sure that we can ask those questions of our citizens in a way that is not offensive as well, and is comfortable for them to share their ethnicity too. Because at the heart of it, none of this is automated. We're not in that territory yet where we can actually do sort of an AI visual scan and then determine their ethnicity and put it into a record just yet. Most of this is captured in person by individuals and then translated into an electronic system. So tailing off, really, it's incredibly important. We are making a concerted effort across the NHS to ensure that data is systematically collated across all our citizen-facing data sets. And we are now encouraging, but also that we use that data in our translation of actual insights too. So making sure that when we are looking at that data in terms of care delivery, in terms of service design, that we're consistently looking at it from those different demographic angles, which include ethnicity. So at that point, I'd like to stop. I think there are other colleagues that will share different perspectives from different angles this evening, but just to kind of share, it is important. NHS is putting a kind of focus on it, and really keen to see actually where that takes us in the future. So thank you very much, and back to you, Marcus, I think.
Thank you so much, Sonia. That's fascinating and a real challenge to us to make sure that we are collecting data in the right way in the first place, so that we then have the basis to derive those insights from. I will hand straight over to Keris, if that's okay with you, to talk about some of the legal considerations that we might face when we're seeking to use and share this data. Keris, over to you.
Thank you very much, Marcus. So yes, I want to talk about the legal issues, but I want to stress that in looking at data privacy and data compliance, the regulators and everybody that works in the area really looks at sharing data in the right way. It's not about not sharing personal data. And I think that's one of the issues that we actually have to deal with, is that people are perhaps afraid of sharing data in lots of circumstances. So just to put that then into further context, what we're seeing is a huge need to share data across the life sciences area in all areas of health. And we've now got the technologies, particularly with AI, in order to make sure that we can actually work with the data and get its best value from that. We're seeing huge advancements in discovery by understanding the data that we can collect, and then in the treatment that can be provided and the medicines that can be developed as a result. So the world is just waiting for the potential of the data that can actually be used. So yeah, we all recognise that. And exactly as was said earlier, COVID has shone a light. When we were talking to life sciences companies at the end of last year, there was very much a willingness and a recognition that we're in a world of personalised health, and that provides much better health treatment. And with that, we've got to process data. But the pandemic has meant that people were prepared to perhaps put some uncertainties behind them and actually move forward and do what was needed for the immediate benefit of the public at large. And from that, we've seen just how much can be achieved. Advances have been made over that time. And one of the things that we have seen from that is that, again, personalizing medicine is absolutely key, because we've seen those different issues for different diverse groups, and therefore it becoming very important to understand that, to understand why is that happening, and then also to be able to deal with the treatment in the most appropriate way. So we recognise that is hugely important. It struck me something I was reading over the last few days, that with Public Health England, one of the universities, the University of Exeter, has been developing a tool because of the issues within the health treatment generally. So a statistic given that 44% of medical staff from Black, Asian and minority ethnic backgrounds work within the NHS. But it was 94% of the doctors who died of COVID came from that background. So it was very stark and very much in the news that this was such an issue. And as a result of that, they've developed effectively a tool that can measure the risks to people. So all of those things make it absolutely essential that we process the data. So where does the law stand on it? So first of all, we've talked about protected characteristics, and that comes out of the Equality Act. And race and gender are two of the key aspects there. And that legislation is all about ensuring equality, making sure that there is no discrimination based on those protected characteristics. Alongside it, then, we have the data protection legislation and the special category data that is part of that. And it has great similarities. So health data is one of the special categories, as is racial or ethnic origin data, genetic data. So all of these things are special categories. So what does that actually mean to us? Well, again, going back to what I said earlier, the law is there to protect individuals' privacy, but it also has a sense to it. It means that actually if we follow the structure of the data protection laws, we get better data at the end. But what does it mean in terms of the steps that we have to follow? So because it's special category data, there's an additional level of protection that's given to it. So we have to have a lawful basis for processing. So it really must be necessary to process that data. You can rely on consent, but if you are going to ask people for consent, it needs to be in a situation where they have full transparency and understand what they're consenting to. So that can be difficult. That consent can also be withdrawn. But if we're going to use it for legitimate interests, again, we have to demonstrate we have a basis for doing that. And we go on further. So once we're in the area of special category data, particularly health data and all of the other issues that we want to process as part of that, then we have to have an additional condition within the legislation. So you can see already there are a number of factors that we have to take into account in order to ensure that we can properly process. And then on top of that, we have to keep it in the most appropriate way, keep it secure, keep it encrypted where appropriate, keep it up to date, keep it no longer than necessary. And then we have challenges around sharing data. And I'm sure most people will have heard about the issues around the international transfers to the US and other countries. So we have those challenges, but again, properly navigated, they can be dealt with. Another area that has been raised as an area of concern is around the scientific research. So clearly that is at the heart of all of this. We have to translate looking at the data into doing the research in order to get the best treatments. And again, there are some challenges to make sure that you navigate the privacy laws in the right way around that. But the positive issue from all of this is that everybody understands the value, and that includes the regulators. So again, COVID shone a light. So we had concerns around the processing of individuals' health data, the temperature checking that was needed really early on, for example. And the great thing was that the regulators stepped in to provide some much needed guidance around this. So the European Data Protection Board in April published a guidance note on processing of data concerning health in the context specifically of research around COVID, which was very gratefully received. And I think, again, it shone that light that we need greater certainty, we need trust, we need transparency around this. So again, the board has promised that during the course of this year, there will be further guidance on the sharing of data. And I think really that's what I'd like to end on, is that we must share data, but we must do it in the right way. What we need to work on is trust, to make sure that individuals actually trust that their data is being handled in the right way. They're prepared to share their data. They understand the benefits of that. They have the confidence. And then we also have the clarity from the regulators, which, as I say, that's what they want to provide. The Commission itself has put out a statement saying that health data is often not available for research, and they want to address that to make sure that that happens. So look forward to discussing some more of these issues in the breakout sessions. Thank you.
Thanks, Karis. Already there's this really interesting theme coming out of those two sets of reflections. One from Sonia around the benefits that data can bring, understanding how care can be improved, for example. And from Karis, just showing how the regulatory and legal environment is actually enabling data. I think we often hear, oh, you can't do that because of data protection law, but actually in that brief review, just showing how you can actually move forward with data-driven projects, even within the scope of data protection law. I'm going to hand over to Noah, who will talk to us a little bit about how to actually then bring that together in practice, because her work is very much at the data science end of things, looking at how you can actually use the data once you have access to it, once it's been collected and then shared it under the appropriate controls. Noah, I'll hand over to you.
Thank you, Marcus. Can you let me share my screen, please?
Sorry, just doing that now.
No.
Okay, you should be able to now.
Yep. Okay, can you see it? Can you see it?
Yeah, we can see it.
Perfect, thank you. So, as Marcus said, I'm living between the worlds of medicine and computer science and data science, and I will try to speak about this aspect of protected variables in healthcare from a very practical point of view. And this point of view is basically the point of view of creating prediction models. And this is something that we do in Kalit on a very regular basis. On this slide, you can see a very selected few of the models that are currently being ran and used on a daily basis in Clalit, solely for the purpose of providing more personalized, proactive, preventive care. And because of that, it's really important for us to know that we are doing a very accurate work at detecting the correct and accurate risk for each individual. And up until recently, the medical consensus was that not accounting for protected variables such as ethnicity or race when evaluating personal risk is unprofessional, and meaning that you would create an inaccurate risk predictor. And many of the risk predictors in medicine were actually very harshly criticized because they were found to be not accurate for specific minority groups or specific subpopulations. So for example, the pooled cohort equations, that's the newer version of the Framingham predictor, if you're familiar with it, for the prediction of cardiovascular risk, was very faulted for providing not accurate risk for specific groups of sex groups, race groups, different groups of income levels, and many attempts were actually made in order to improve this situation. A more historic study actually tried to collect a cohort of patients that are more diverse in terms of ethnicity. It's called the multi-ethnic study of atherosclerosis, the MESA studies, also a very famous study, which basically meant that accounting for variables, for protective variables such as race or ethnicity is very important, and you should go a long way in order to make sure that you do an accurate job in assessing the risk for different individuals. And if we follow this paradigm that you need to really create a very personalized and accurate risk prediction model for every minority groups, then you need to account for many different aspects and many different protected variables. So for example, if you would consider different ethnicity groups and sex categories and age categories and maybe socioeconomic status categories, and you want to simultaneously take care of all of these populations and make sure that you're accurate for each and every one of them, then you have many subpopulations that you need to worry about. And this is a real problem. This graph is an example of our attempt in using the Clalit data. So Clalit is a large healthcare organization in Israel. And basically, this is our attempt to use the pooled cohort equation model on the Clalit population. And we can see that for many subpopulations, presented here as different dots on the x-axis, the calibration of the model is very off. And that means that those subpopulations will receive very inaccurate predictions. And that means that we have a problem. And we've actually worked really hard in trying to solve this problem and use, for example, a special algorithm for multi-calibration, post-processing the predictions that came out of the pooled cohort equation models in order to make sure that they are more accurate for different subpopulations. And we were pretty happy with this, and we felt that we did something very responsible, but because usually when you talk about prediction models in medicine, if you would read papers in the most high impact journals, you will always see the overall performance measures. It's very rare to see any discussion regarding the performance of the model, the accuracy of the model towards different minority groups. So we actually thought that we were doing something really good and right. But then it seemed that very recently there seems to be a change in consensus. So I don't know how many of you came across this very recent article from the New England Journal of Medicine, which is getting a lot of attention in the past month, which basically says that something is wrong. Using race and death as such a dramatic variable in medicine is not the correct thing to do, usually, because although we seem to think that race maybe reflects a very reliable proxy for genetic difference, maybe in many circumstances, it actually reflects of race-based health inequalities, and using that race and they basically go through different medical domains and show you that like the very basic fundamental truths that we are told in medical school, that, for example, when you measure the kidney function for different race groups, you need to use a different formula, and they basically tell you that this may be wrong, and they really go like one clinical domain after the other, basically challenging every medical truth that I was taught in medical school. And they seem to think that we need to really think it through before we use race variables, for example, in prediction models. And that is really confusing, because what should we do? What is the correct thing to do? Should predicted variables be included in prediction scores in medicine? Should we take, if the answer is yes, then should we take the extra step like we did to make sure that we're accounting for different predictive variables simultaneously using algorithms such as the multi-calibration algorithms? Or should we ignore them altogether because they actually reflect some sort of social deprivation that we don't want to now relive using our models and our decisions that are based on our models? I would claim that this is not such a black and white decision, and we need to think long and hard on every protected variable when we use it in such models. And basically, I would suggest a three-way scale to make this decision. So basically, when we think about every protected variable, and this is what we currently do, we should think about whether or not, or how likely is that variable to reflect some social deprivation, or on the other hand, how likely is the variable to reflect a true genetic difference with regard to the prediction that we're trying to make. And it's not always that clear that if the variable actually represents social deprivation, then we shouldn't use it. And that is the third point I want to make. And that is that it really depends what will we use the prediction results for. Because we're, for example, a healthcare organization that is by law giving both coverage and actual medical services to Clalit members. And we, again, by law, cannot deny coverage for any patient, no matter what's the medical history. And we're being paid by capita. So basically, our sole intention is to do as much as preventive medicine as we can, because it's good for the patients and it's good for the system. And the system is well built on that respect. And if we were to make a prediction model that tries to detect specific populations that are, for example, of a high predicted risk for cardiovascular events, and try to do some intervention in order to prevent that event, then I would want to identify patients who are of the highest risk, whether that risk is basically their genetic tendency, or maybe because they were more socially deprived and they have a higher risk. And we know that low socioeconomic status groups do suffer from higher risk, from a higher risk. So those are the patients who actually need us the most, and we want to identify them as having a higher risk so we can really give them the better care and the more proactive and preventive care that we can give. If, on the other hand, we were to develop a model that for health insurance company that would use the higher risk or a higher predicted risk in order to deny coverage for some patients, then definitely it's not ethical, and they shouldn't use variables such as ethnicity and race in order to make these decisions. So just to say that the multi-calibration work that was presented here was performed in collaboration with many people, and I hope I gave you some food for thought about how hard it is to make these decisions, or whether or not to include predicted variables in prediction models in medicine. And I think I will stop here.